Over to the next session, the most heart-throbbing situation for the IVF team and even more to the couple is the unexplained infertility. And now I invite Dr. Varsha to explain the situation. Dr. Varsha had earlier worked at, she's from the Vijayawada Center. She has earlier worked as an assistant professor in SWIMS Tirupati. She had done fellowship in reproductive medicine and course in OBG ultrasound, in gynae endoscopy, had presented many papers and contributed to textbooks. Dr. Varsha, please continue.
Thank you so much, dear Chairperson. So good afternoon, all of you. So greetings to all of you from Vijayawada, and all of us definitely come across this situation where the couple comes to us saying that we've been to so many doctors before this, we've had so many tests, always the tests are turning out to be normal, everything is normal, but we are not getting our pregnancy. We have spent lakhs of rupees, but we don't have an answer, and they come to you with that $1 million question of why are we failing. So today I'm going to talk about this enigma of unexplained infertility. Now, why is this important? Why is this topic important? Firstly, because it is as common as 30% of all infertile couples that we are looking at. So 30% of infertile couples, they try for, they have unprotected intercourse for 12 months or for 6 months if the female is more than 35 years, and they get their investigations done, they are normal, and they come to us. And the second thing is, when we are fighting an invisible enemy, it is always better that we have some guidance, right? So that is the importance of this particular topic. So coming to the definition, so different, the RCOG guidelines are there, we had the ICMART guidelines, we had the ASRM in 2020 and the ISHRE in 2023 with different giving us a guidance of how do we label a patient as unexplained infertility. So the most recent was the ISHRE guideline in 2023, where they say that we have to document ovulation. This could be with either a positive LH, LH kit test, or an ultrasound monitoring, or a mid-luteal progesterone. We should document patent tubes with a HSG or a HyCoSy. You need not do a laparoscopy for all your patients. A simple HSG or a HyCoSy is sufficient. And a standard semen analysis. 2020-21 guidelines followed WHO lab standard semen analysis. If these three are normal, then you can probably label the patient as unexplained infertility. But the question is, are we excluding enough? Okay, by doing a scan, a tubal patency test, and a semen analysis, are we actually excluding enough? If we are, then why is the patient not conceiving? So what are we actually missing at? So are there anything else that we can be looking into, which could probably be the reason for her infertility? So there are so many things that we actually don't test. When we are doing these standard 3 tests, we do not know about the oocyte quality. We do not know about the sperm function. We measure the count, we measure the motility, we look at the morphology, but we do not know the functionality of the sperm. There are so many tests that we can do to know the function. It could be a DNA fragmentation, it could be a vitality test, it could be, as Chaitanya sir was mentioning, the ROS levels. So there are so many such tests which are available. Functioning of the tubes is not tested. The tubes being open does not necessarily mean that they are functioning. Now we have the chlamydia antibody tests that are available, and if the chlamydia antibody test is positive, it is suggested that the patient go through a laparoscopy to find out the functionality of the tube as well. Sperm cervical mucus interaction, endocrine problems like thyroid or prolactin disorders, autoimmune, there is a whole spectrum of autoimmune diseases which we are actually not testing. Endometrial receptivity, a lot of work has been done in this area where we do the endometrial receptivity array to find out if the endometrium is receptive, pre-receptive, non-receptive. Hysteroscopy to rule out uterine abnormalities which are not otherwise picked up on scan. Laparoscopy probably to diagnose a stage of endometriosis which cannot be picked up on scan, or adhesions in the adnexa, which you don't normally see on scan. So there are so many such things which we are actually not looking at before we label the patient with unexplained infertility and go for a treatment. So does this mean that we have to do all of these tests and actually find out what the reason is and treat? Because if you don't know what to treat, what are you going to do with the patient? So this is a never-ending debate, and there are some people who say that there is, it's a bogus diagnosis. You have to go into the depths of all these things that we are missing, find out the reason and then treat. And there are some who says that, it is pretty reasonable to label the patient as unexplained and go ahead with the treatment, because finding out the reason with so many investigations may not actually change what you are going to do with the patient. So looking from the patient's point of view, are so many investigations justified? Basically, what does the patient want? The patient wants a faster success with a reasonable cost, a lesser treatment burden, probably lesser time to pregnancy and lesser cost to the patient. So the recent ISHRAE guidelines 2023 have said that a 3D ultrasound could reasonably rule out uterine abnormalities, and a laparoscopy is indicated only in patients where you have an abnormal HSG or a history of PID, previous ectopic pregnancy or a known endometriosis. Apart from this, laparoscopy is not required. Now what about the male partner? So I told you we have so many tests available for the male partner, but ISHRAE 2023 guidelines have re-emphasized that if the standard semen analysis is normal, you don't have to further evaluate the patient. So having said that, we are now convinced again that it is only 3 tests that we need to do. That is, diagnose ovulation, look for tubal patency, and a standard semen analysis. And if these are normal, we can label the patient as unexplained and probably proceed for the treatment. So what are the options that we have? So we can go for an expectant management. See, everything is normal. You just reassure the patient, convince them that they can try for some more time and go for an expectant management. Or you can go for a simple ovulation induction and timed intercourse, or intrauterine insemination with or without drugs with oral ovulogens or gonadotropins, or the last option would be IVF or ICSI. So because we don't find a cause, expectant management has a lot of weightage in unexplained infertility. There are a lot of studies, there are a lot of guidelines which actually say that, expectant management is the way forward, because in the first year after you diagnose unexplained infertility, 15 to 20% patients conceive. In the second year, almost 35 patients conceive. And in the third year, by the end of the third year, by expectant management, a few old studies have said that almost 80% of the patients conceive. But can you convince the patient to wait for that long? So it's not easy. You tell the patient who has already been trying for 1.5, 2 years comes to you and you say that, hey, everything is normal, you wait for 1 more year. So it's not easy to convince that particular patient. So what does the evidence say? So when it comes to unexplained infertility, we have various guidelines. We have the NICE guidelines in 2013. We have the ASRM guidelines in 2020. And we have the ISHRAE guidelines which were recently published in 2023. So they're all guidelines which are almost 80-100 pages. I'm just giving you a brief summary of it. So the NICE 2013 guideline says that you have to try for 2 years with expectant management, and if it doesn't work, go ahead with IVF. So 2 years of expectant management means if the patient comes to you with 2 years of unprotected intercourse already, you don't wait for 2 more years, you go ahead with IVF. If the patient comes to you with 1 year of unprotected intercourse, you'll ask the patient to wait for 1 more year, and if she doesn't conceive, go ahead with IVF. No role of oral ovulogens, no role of gonadotropins, no role of IUI, no role of timed intercourse, directly IVF. Easy to convince your patients. It would then later on a survey in the UK itself, it revealed that many in UK itself were not able to follow this protocol. So now what about the ASRM 2020 guidelines? So ASRM 2020 guidelines says that ovulation induction and timed intercourse is no better than an expectant management. So you're not doing anything great by just giving ovulation induction and timed intercourse. IUI with oral ovulogens should be tried for 3 to 4 cycles. IUI with gonadotropins, they said no because of the increased chance of OHSS and multiple pregnancy. And then 3 to 4 cycles after oral ovulogens and IUI, they don't conceive, go ahead with IVF or ICSI. So this was ASRM 2020 guidelines where they are very cautious about using gonadotropins for the simple reason that they don't want OHSS and multiple pregnancy. See, in our country, people are very happy with a multiple pregnancy. But definitely as an obstetrician, we know what it is to have a multiple pregnancy, what is the treatment burden that the patient may have to go through and what are the complications the patient has to go through. Now the recent ISHRE guidelines 2023 says, oral ovulogens and timed intercourse is not going to help us better than an expectant management, but IUI with ovarian stimulation has to be done for 3 to 6 cycles, which includes even gonadotropins with low doses with adequate monitoring. You should have strict cancellation criteria, so that you avoid the complications, but you get the benefit as well. And if this doesn't work, go ahead for IVF or directly go ahead for IVF based on the patient's profile, based on how many years she's been married, her age. So if she has anything else which says that, okay, she can go ahead for an IVF, go ahead. So now these are the 3 guidelines for you. I think I've created enough controversy to all of you. But one thing I want to highlight, getting back to the guidelines, is all the 3 guidelines tell us that giving only oral ovulogens to the patient is not going to do any more benefit to the patient. So if a patient comes to you today with all the 3 standard tests being normal, by putting her again on oral ovulogens for 3 cycles or 6 cycles and just waiting, you're just going to waste her precious time. And it's been proven beyond doubt by all the 3 guidelines that we have. So what are the options that we are actually left with? Either we go for an IUI or we go for an IVF, and that you can stratify based on your patient's profile. Now, if I have not confused you enough, I have 2 more papers or 2 more trials to be discussed. One is the FAST trial and one is the FORT trial. Now, the FAST trial, the study population is between 21 years to 35 years. So they divided their patients into 2 arms. The first arm, they had CC with IUI for 3 cycles, followed by gonadotropins with IUI for 3 cycles, followed by IVF for 6 cycles. The accelerated arm, they used CC IUI for 3 cycles and then went to IVF 6 cycles. Now the results show that there is a decreased time to pregnancy and decreased average cost, cumulative cost in the accelerated arm. Now all this is possible in UK where everything is funded, but I'm just putting it for your reference. Now the 4th trial is where, now this was, the FAST trial was for 21 to 38 years, and now this is for 40-year-old females. So now again they have divided into 3 arms where you have cycles to CC with IUI followed by IVF in the first arm, FSH IUI followed by IVF in the second arm, and immediate IVF in the third arm. And here again they say that immediate IVF demonstrated superior pregnancy rate with fewer treatment cycles. So with all these guidelines and these 2 trials, what are you actually going to do? Again, coming back, the patient wants fast success and lesser treatment burden. And I would like to emphasize on this particular line, which we have been discussing since morning, that actually evidence is not meant to define your practice, that you do only this. It is only meant to refine your practice. So ultimately, you have to figure out a practical option which you can follow with your set of patients in your scenario, in your place, right? So what we normally follow is if the patient is more than 38 years, convince the patient for IVF, that should be the best option. If the patient is less than 30 years, probably think of 2-3 cycles of, we do a combined oral ovulogen gonadotropin cycle. We don't do only gonadotropins, keeping the cost in mind, keeping the success rate of IUI in mind, and if it doesn't work, go for an IVF. So 2 options, one is IUI, one is IVF. Now, is there something better we can do in these 2 in patients with unexplained infertility? So, you're anyway shooting arrows in the dark. You don't know what you're treating, but you're treating. So, can we do something better in these patients? So, coming to IUI, there are a few strategies which can probably help you improve your success rates in patients, especially with unexplained infertility. So, try and go for a superovulation. So normally when you want to induce a patient, you want monofollicular development. But in patients with unexplained, probably aim at getting 2 follicles. So studies have shown that as the number of follicle increases, second follicle or the third follicle, the pregnancy rates increase, and beyond that actually it doesn't make much of a difference, but the chance of multiple pregnancy increases. So try and get 2 follicles and probably it will increase your success rate. But in the process, you should have a strict cancellation criteria as well. So if you have more than 3 follicles of 18 mm or more than 5 follicles of 12 mm, definitely you have to cancel that cycle. So keeping this in mind, with strict ultrasound monitoring, go ahead with gonadotropin IUI cycles, try and get 2 follicles and do an IUI. Now what about the sperm preparation techniques? So my embryologist had discussed about the sperm preparation techniques. We have evidence that when the patient is normozoospermic, going for a simple swim up will give you decreased chances of having DNA fragmented sperms, and it gives you a better outcome. So when you're doing a density gradient method of sample preparation, you're subjecting the sperm to centrifugation, which could probably increase the DNA fragmentation. So consider just simple swim up, because these patients have a normal sample. You know, the semen analysis shows normal count, normal motility, normal morphology. You just want to filter out the motile sperms and do an IUI. So go ahead with a simple swim up. Now, is there a role of a double IUI? So in unexplained infertility, because you want to give more gametes, probably get more follicles, put in more sperms, does it help? So evidence has shown that doing a double IUI actually does not have much of a benefit even in unexplained infertility, and this has been reaffirmed even in the recent ISHRAE guidelines, that a single well-timed IUI is more than enough for your patients with unexplained infertility. Now what about in IVF? Can we do anything different? So we were talking about ROS levels, probably they could be high in unexplained infertility. So can we use some adjuvants? Will antioxidants work in these patients? So should we give our patients 2-3 months of antioxidants before we proceed for an IVF? So evidence says that there is no role of giving oral antioxidants to these patients with unexplained infertility, and it is not improving the live birth rate or the outcome. Now what about sample preparation? So can we use a microfluidic chip to select the least DNA fragmented sperm for your patients with unexplained infertility? Yes, a few studies have proven that if you use a microfluidic chip, you get better quality embryos, better chances of getting top quality embryos, but there is not a significant increase in the live birth rate. So again, you have to take it with a pinch of salt. Now, do we have to go for ICSI for all? So in unexplained infertility, we could probably think of fertilization failure as a cause for infertility and think of going ahead with ICSI for all. But again, time and again, all the studies have proven, and even the ISHRAE guidelines, ASRM guidelines have told us that there is no difference whether you go ahead with IVF or ICSI. So you don't have to do ICSI for all in your patients with unexplained infertility. So putting all this in a nutshell, the diagnosis is important. So doing a simple scan, a semen analysis and a tubal patency, you should be diagnosing an unexplained infertility. But make sure that your tests are done in a standardized way. Okay, so see that your semen analysis is done in a proper standard lab who follows the guidelines. So as sir was telling Chaitanya sir, he said that so many reports he still sees where they say the normal count is 40 to 60 million. And we also come across so many reports which say normal forms are 80% and 90%. So how reliable are these tests? So think about the reliability of where you're getting your semen analysis done. Tubal patency. So we had a patient where we had normal tubes, we did 3 IUIs, everything was looking normal. She didn't conceive, then we did a laparoscopy, we found out that the tubo-ovarian relation is altered. The tubes are not actually sitting on the ovary is somewhere, the tube is somewhere. So that has to be looked into. Coming to scan, antral follicle count measurement is extremely important. So we should not be missing out on our poor ovarian reserve patients. So now having a normal reserve and seeing all that and labeling the patient unexplained infertility is extremely important. So these simple things should be done to make sure that you are actually diagnosing the patient correctly and putting that patient into the right pocket. So ultimately IUI with ovarian stimulation is recommended. Aim at 2 follicles. IUI with simple wash, single IUI at 36 hours should do. decision for IVF should depend on number of factors. We normally, with a patient with unexplained infertility, as I have pointed out, if the age is slightly lesser, we try 2-3 cycles of IU and it doesn't work out, we go ahead with IVF. And your ultimate trump card should be that in this process, anytime you can conceive normally. So you advise an IVF, the patient comes to you with a pregnancy, the next month she'll think that, you know, you're doing unnecessary treatment. So you counseling the patient and telling her that expectant management actually has a role. Even if the patient is in treatment, during the treatment also you should be encouraging her that any month you can conceive naturally, you keep trying. So thank you so much for your patient listening. Though I was the only one between you and your lunch, you were very attentive. Thank you so much.
Thank you, Dr. Suma. You explained unexplained infertility very well. And I think, I don't know, I'm not an expert in this. Before declaring unexplained infertility, I think you need to do at least histology. You said some points now.
Diagnosis, actually, the evidence says it's not required, madam. But yes, in certain situations where you're suspecting a PID or suspecting an endometriosis from the history, or something which points out that you could probably be missing on something, you can go ahead. But doing a diagnostic histrolab for all patients who have a normal tube, a normal semen analysis and a normal scan, I don't think it's recommended. Stage 1, stage 2, yes sir, you cannot detect it. But stage 1, stage 2, you can still go for ovarian stimulation and IUI even without doing a diagnostic histrolab.